All right, thank you. And thanks to everyone for inviting me to talk a little bit about a topic that I've been working on for a very long time, which is how to measure change in development and cognitive ability in individuals with neurodevelopmental disorders. So what I'm going to do today is talk a little bit about the challenges of why this is hard and give some examples of that. And then I'm going to talk about some conditions where we've overcome those examples in specific ways, and then talk about how we've kind of applied what we've learned over the years to n-Lorem patients and what they're doing. So reversing neurodevelopmental disorders was, the brain is a very complex organ, and it has a long period of development where cells have to go to the right place, and then they have to organize themselves, and they have to be there in the right percentages, and they have to create a neural network, and then they have to be able to regulate synaptic connectivity over time throughout life. And so this is a pretty complex process to recapitulate. And when this goes wrong and you have a neurodevelopmental disorder with intellectual disability, it was thought in the past that one could never replicate that, and you really wouldn't be able to improve cognition and development, and intellectual disorders would be impossible to treat. More recently, there have been a lot of advances in molecular neurobiology, and this has been questioned, and it was thought that at least maybe if the protein that is abnormal in the patient does something needed minute to minute for synaptic connectivity, you might be able to actually improve cognition, even if you couldn't correct it completely. And actually, Fragile X syndrome was the first place where we tried to do this. And when I ran a trial in 2002, where we used a drug to increase AMPA activity, that we had shown that there was too little AMPA activity in the cortex of the mouse with Fragile X. And so we tried to improve cognition that way. We discovered in that study that we had a lot to learn, basically. So since this concept has been furthered with more neural and genetic treatment targets in Angelman, Rett, Phelan-McDermott syndrome, and others, and now in neurodevelopmental disorders for patients who are in N-of-1 and n-Lorem trials. And we've really refined the outcomes and the measurement, and you'll see why we've had to do a lot of work to figure this out. So cognitive and developmental endpoints are really a challenge. The standardized, validated tests were not created or standardized on an intellectual disability population. The people have floored test scores. They're likely to need something called deviation scores, where we actually kind of create a curve based on how far from average they are. The test may not even be possible for the range of ability in the patients, and we may not be able to use an age-level test. Standard scores may not detect change because of floor effects, and we have to use change-sensitive scores called personability scores, which are also referred to as growth score values, to be able to actually look at change. The test may not be granular enough for adequate sensitivity, even if the patient can take the test, and we may not be able to detect important relative improvements in a neurodevelopmental disorder because they're just on a different scale from typical development. And then variability and ability level may not allow us to even give the same test to everyone with the disorder, and the patients themselves are often hard to test because they don't want to do the test, and then they have behavior, and you need really experienced testers. So I'm going to run through some examples of that problem. So in Fragile X, if you look at the little graph in the middle, I don't know if I have a pointer, right here, but so if you just give a Stanford-Binet intelligence test to people with Fragile X, the vast majority of the population is going to score at 40. Why? Because that's the floor of the test. But David Hessel has now developed what we call a z-deviation method, where we can actually get those patients on a curve and actually measure that cognitive ability below 40, and then we can really see the distribution of cognitive ability in Fragile X, which we never knew in the past because we thought they were all like 40 to 45. And then this allows us to predict how well they might do different things in life, for instance, because we know what the actual cognitive ability is. So this was an important advance in terms of understanding the spectrum of cognition in Fragile X syndrome. But in some disorders, we can't actually give a standard IQ test. So this is Angelman syndrome. And it was always thought that, well, it wasn't valid to give an out-of-window test, like to give 8-year-olds a test that is only normed up to age 3 or 4. But we've had to do that in some developmental disabilities. And Angelman syndrome has been a really good example where they took this, they adapted how you give the test to meet the needs of the Angelman population, which was where the patients were going to be older, but they were going to take this test for young children. And so over 15 years of natural history, they've mapped, this is the developmental trajectory of patients with Angelman syndrome, and this gray area is typical development, and you see that stops at 3.5 because the test is no longer valid. But patients with Angelman syndrome don't ever get over that age range, so we can actually look at their trajectory of development by using this test. And so this is one way of adapting a test to a disorder so that we can actually understand what the baseline cognitive change is. Using standard scores is really a problem in these disorders because you can't actually detect change. If your score is 40 and it's at the floor of the test and you get a lot better, your score can still be 40. If you have a degenerative disease, for instance, then it won't necessarily detect change. Standard scores always look like they're going down in patients with developmental disabilities with time, because as the patients get older, they get further and further from typical. And those scores are always relative to what a typical child should do. So we need to use something else. We can use raw scores, but those are they go in fits and starts, like they're not evenly distributed. You might go up 1 point on the test, and then you might make a lot more change to go up the next point. So those have been evened out with what's called growth score values, which have been, kind of statistically changed so that 1 point of change is the same across the entire test. We also sometimes use age equivalents, and these are nice for families because they help you understand at what age level is my child functioning at, but the transformation used for those is something that the FDA does not accept as mathematically accurate. So we don't use that for trials. Even if we give a test, like in Angelman syndrome, where we've adapted the test, we're using growth score values, but sometimes there are really important changes that happen that aren't detected by the test. And this is just a little study we did after we had 40 Angelman patients on antisense oligonucleotides to correct their disease. And we reviewed all of their visit notes, which was like 354 notes, and looked at the skills that these patients had gained, and then asked, are these detected on standardized tests like the Bailey, which is this developmental test that we give out of age range to Angelman syndrome, or the Vineland, which is an adaptive behavior test that covers all age ranges. And what did we find? We found that all the green group were skills that were not even assessed on the test, like swimming, for instance. And then all the purple things were things that they were asked about on the test, but the patient had a meaningful improvement that was not actually assessed based on the way the test was set up. And then the blue are the things that were actually detected. So in other words, a person with a severe developmental disability can have improvements that are very significant to families that are undetectable even when we adapt the testing. And then we can have diseases like Phelan-McDermott syndrome, and this is just the natural history study of Phelan-McDermott syndrome, where we have all these people in the blue circle who need to take a test that's closer to an age level test, who can do like a standard IQ test or a standard language test, and then we have all these people who can't, and so they have to be tested with a test that's out of age range. So roughly 40% of these patients have to be tested with a test that's out of age range, and the only way for us to study the entire population is to use multiple tests, and that creates a big problem with trial design and following patients when we're trying to study something in the whole disease. And then, the population that we test is not just any psychometric tech can come in and test this population. They are very unique. They have different behaviors. the Angelman patients can figure out every imaginable way of getting out of doing the Bailey, and as they get a little bit smarter on the drug, they get a little bit more sophisticated at how to avoid doing the test. And so you really have to navigate this, and you need to have very experienced people delivering the test, and you need to have, even though the test is generally a good test, you have to have it administered at a time when the patient is likely to cooperate, you have to have their favorite snacks there, and you have to have a very trained clinician to keep these patients on task and doing the test. So in Angelman syndrome, I think Angelman syndrome is a great example of what an ASO may be able to do, and this is a severe intellectual disability. Most patients are nonverbal, they're very delayed with motor skills, they have ataxia and tremor, and all the problems that lots of kids with more severe intellectual disabilities and neurodevelopmental disorders have. Sleep problems, seizures, behavior problems, with a whole list of behavior problems. And they can be a little bit dysmorphic or unusual looking, but this is pretty variable. They all have loss of UBE3A expression from the maternally derived chromosome 15, and that's because the expression of from the paternally derived gene in neurons is blocked by a long antisense RNA that's transcribed on the opposite strand into the gene. And so patients can have deletions, mutations in their maternal UBE3A gene, or they can have 2 chromosome 15s from their father, or they can have an imprinting center mutation that turns their mother's chromosome into a chromosome that looks like their father's chromosome. But we can use an antisense oligonucleotide basically to, I want to go back, basically to target that long RNA, to bind to it, and then it looks like double-stranded RNA, and it's degraded by RNase H. So we can do that. And if we look at what has happened so far in 3 antisense oligonucleotide trials to try to do that, and were we successful in measuring cognition with the strategies that we developed through natural history? Yes, actually we were. And in fact, we can see that even though everyone's at the floor of an age-based test, we're using the Bailey out of age range, we're using GSVs, at least all the patients can take the same test because they're all in the same cognitive range. And then we used raters. We had extensive training for raters. We still miss, as I showed you in the previous slide, many of the changes the patients happen. But even with that high bar, we are able to see that these patients in blue are making progress at a very different rate from natural history. And this is the Roche study, Tangelo, this is published. This is also data from the Ultragenic study and the Ionis study that in all cases shows the treated patients are doing better than natural history. So fortunately we had that natural history, and that's provided the impetus to go to phase 3 trials. And likewise, these patients have shown a change in delta power on the EEG, which correlates with cognition in Angelman syndrome. And this just shows you from the Roche study, again published, that not just the cognition domain, but all the domains in the Bailey are generally improving relative to natural history. So we can get diffuse changes. Okay, go. Likewise, in Rett syndrome, natural history has really informed us in how to measure this cognitive change. So in Rett syndrome, there are over 1,000 patients in a natural history study that went on for 15 years. And so one can demonstrate with great power that after patients with Rett syndrome, we talked about this yesterday when the question came up, after age 6, patients with Rett syndrome, of course, they lose development, they make some development, and then they lose developmental skills, but they don't, if they never gained a skill, and if they lost a skill, they virtually never regain a skill after age 6. So that provides us with an opportunity to use the patient as their own control and figure out exactly where they are when they come in to the trial with which skills they have, and use the ability to gain a skill as a primary endpoint for gene therapy. And so both Neurogene and Tasia are using this strategy. They both did an independent analysis of the natural history data, and what did they come up with? They came up with a list of developmental skills that when they interviewed families said these were important. And actually, in terms of the list, there were only 3 things that were different in the 2 companies' analyses. So Tasia has, the black things are things in Tasia's list, and then Neurogene has doesn't have those, but they have a few different ones. So very consistent analyses can be generated from this, and now both companies are doing registration trials with this as the primary endpoint. And this is a really novel way of using natural history to inform a patient as their own control model, and is another way of looking at development in cognitive/developmental gain in a disease that can't take any of our standardized tests because of their inability to both use their hands and their inability to communicate verbally. Okay, so how does this tell us what to do in N-of-1 trials? So we have the added bar of not having those lovely natural history control groups that we have in Angelman syndrome and Rett syndrome. And we don't have an internal control group. We're not doing, obviously, placebo-controlled trials. So the only way for us to really assess cognitive change is to look at pre- and post-treatment with the patient as their own control, but we really only have one patient to be their own control. And so what we can look at is an increase in the rate of change of a GSV on whatever measure is appropriate for the patient, before they go on treatment and after they go on treatment. This is why we're talking yesterday about how important it is to have that lead in. So, even if your ASO isn't ready, the more time we have while that ASO is getting ready to be able to assess the patient as they go in, that's what allows us our baseline. So if we imagine this is the rate of typical development, and this is the rate of our patient with a neurodevelopmental disability, then we're going to give them an ASO to treat their genetics. What might we see? We might see nothing, because it's possible the disease isn't treatable. We might see a change in trajectory, so it goes up closer to normal. We might see a change in trajectory, so it goes up, but it doesn't go up as fast as normal. It might go up some and then taper off, because the only part we can treat of this is the part that has to do with the protein's acute effect on synaptic plasticity, and we can't get at some of the developmental things that are more permanent. So we might see any of this. But what have we seen? So we have an N-of-1 trial for SCN2A with an allele-specific ASO from n-Lorem, and this is a patient with a severe neurodevelopmental disorder with intractable seizures. He's nonverbal. He's been treated now for 2 years. His seizure control has improved but not gone. He's off Dilantin. We have to test him out of age range and use GSVs because he can't test within age range. And we have a very experienced tester who works with him. And so what we've seen is there have been gains in GSVs across the different domains of the Bailey. And then this graph, and this cognitive bar might be a function of just testing variability, but on most of the tests, he was kind of, when the bars go down, it means that the patient was scoring lower as time went on, and that can also be due to variability or maybe having seizures or whatever. But what you can see is that more consistently he was getting lower over the time before he was treated, and the time since he's treated, he's looking like his rate of change. These are rates, they are not absolute numbers. This is the amount of change per year, or the annualized amount of change in the GSV score. So it looks like it's going up here. And as I was saying yesterday, this is 2 years, but to really solidify this and know what we have, we probably need another 2 years. I mean, it's a long-term thing to figure this out. This is a more recent patient with PAX1. We're treating her with a non-allele selective ASO from n-Lorem, and she has a severe neurodevelopmental disability with seizures and is nonverbal. She's been treated for 6 months. She's had no seizures since she started the ASO in a setting where she often will have recurrences at sort of the end of the summer, and has been tested out of age range again with the Bailey using growth score values. And so we just got this yesterday, we just analyzed this yesterday, but the improvements in her rate of gain on these different subscales, you can kind of see this is her rate of gain, and then things seem to go up a little bit here at the end. And when you plot change again, okay, so this is, the blue bars are her rate of change per year on all these different subtests before she was treated, and then the orange is her rate of change after she was treated. So this looks like she's making more progress. Again, this is 6 months and there's testing variability, so we need time to understand if this is really going to be what we're going to see. And we'll continue to follow this, but this is hopeful. Okay, so in conclusion, it's a challenge to measure cognitive and developmental gains in patients who have challenging neurodevelopmental disorders. We have to make modifications from traditional testing to show cognitive and developmental change. We have to be willing to accept that. And despite the hurdles, though, we're beginning to actually have ways of showing cognitive or developmental change with therapeutics that correct the genetic cause in neurodevelopmental disorders. We don't know how much benefit or normalization can be seen at what age of treatment initiation, over what time frame, and with what disorders. There are different molecular mechanisms of all these disorders, and the neural impacts are likely variable in terms of how correctable they may be, and they likely exhibit different age dependencies. Some you may have to treat the patient right at birth, others you may be able to get the patient later and change things. Some may have a critical window. We just don't know, and so we're going to find out, though. The key is that we're going to find out because we're doing all this treating, and so these studies we're doing right now are going to let us know how correctable at what age each condition is and finding out what benefits. So not only are we treating patients, we also have the opportunity to learn what these proteins do and when they're important by seeing how much change we can enact at what age. And so from this, we're going to learn more about the neural functions of the proteins that are produced by the genes we're correcting, and we're going to make advances in neuroscience. So we're treating both patients, and we're learning a lot. And acknowledgements, I just want to acknowledge my Angelman team and my N of 1 team, and who are mostly here at the table back there. And then our industry partners, but also the foundations we've had funding for, particularly n-Lorem. And I think a big point to emphasize here is the different rush services that we've had to bring in, because you have to have a lot of cooperation from the hospital, as everyone knows who does this. And so we've had a lot of collaboration with all of these different groups at our hospital. And of course the families, because the families go through a lot to help us. They're our partner in treating their child, but also they're there to help us learn and make progress in how to treat other patients in the future and how to understand what the brain does. And that is it.